Thank you very much, and thanks to the IAS and for all of you for being here today. I want to begin by acknowledging my collaborators at the Inova Health Institute and the Vitz Reproductive Health and HIV Institute. All authors are listed here. Our work was sponsored by the President's Emergency Plan for AIDS Relief in the U.S. Centers for Disease Control and Prevention through a cooperative agreement with the University of California, San Francisco. And the views expressed here are those of the authors, and I have no conflicts of interest to declare. To begin, while there's never previously been a systematically conducted HIV surveillance study with female sex workers in South Africa, there has been some research over the last 20 years, and all signs pointed to a high burden of disease, with roughly half of all sex workers recruited into these studies being HIV infected. Additionally, a modes of transmission exercise for the last National Strategic Plan for South Africa considered all the evidence and found that estimated that 20% of all HIV infections in South Africa were attributable to sex work in some way. So this is the context in which we began the South Africa Health Monitoring Survey with female sex workers in 2013 and 2014. We recruited in South Africa's three largest metros, Johannesburg, Durban, and Cape Town. Our inclusion criteria were female sex at birth, aged 16 or older, and who had received money for sex from someone other than her main partner in the prior 30 days. Recruitment took place through respondent-driven sampling through sex workers' own social and professional networks. The methods were a 90-minute behavioral survey, rapid HIV testing with results return, and serum collection for HIV surveillance testing per WHO guidelines. The data I'm presenting today, our statistical analysis, we used respondent-driven sampling analysis tool, or RDSAT, to estimate HIV prevalence and prevalence related to continuum of care indicators, and multivariable analysis using SPSS on demographic, structural, and behavioral variables related to the sex work environment or to health-seeking behavior, using binary logistic regression with backwards conditional elimination on an HIV outcome. So first, the HIV prevalence results confirmed an extraordinarily high burden of disease. Francois Fenter presented this slide in his plenary on Monday. There's really no way to dress this up. It's awful. But there is some good news. Most women who are HIV positive, most female sex workers who are HIV positive already know their status, particularly in Johannesburg and Durban. Very low numbers, comparatively low numbers of undiagnosed HIV infection. But of particular concern is the number of recent HIV infections that were reported. These women had had an HIV negative test within 12 months of their survey participation. So this is indicative of a very high incidence epidemic. So moving on to our multivariable analysis, I first want to focus on the structural environment of sex work. And here we see a lower odds of infection among those exclusively brothel-based workers in Johannesburg compared to those working on the streets. And this stands in contrast to what we saw in Cape Town and Durban, where women working exclusively in brothels appear to have a greater odds of infection. Now we think this reflects the differences that are related to health outreach. Our partners in Johannesburg, WRHI in particular, have been working in the local brothel environment very effectively to reach sex workers with information and make them aware of health services that are available to them. And in contrast, no organization has comparable access to these environments in either Cape Town or Durban. And in fact, our study team had trouble accessing women in brothels to promote the study, explain the study, and encourage their participation. So I think this is a critical consideration for intervention moving forward. Now, switching our focus to healthcare utilization variables, we found that most women have access to healthcare, and that HIV-positive women actually had a higher odds of infection, of accessing some form of health care, either antenatal care in the last 5 years or care for any illness in the prior 12 months. And I want to make 2 points here. So in general, sex workers are not unknown to or outside of healthcare networks. And HIV positive women in particular are at least as likely or slightly more likely to access available services than HIV negative female sex workers. And as I noted previously, most of those HIV positive women are already aware of their status. So we ask the question, does this translate into optimal results across the continuum of care? And the answer, unfortunately, is sort of. This figure shows the proportions of HIV positive female sex workers aware of their status, those voluntarily linked to care within a month of diagnosis, and those on ART. And there's 2 points I want to make here. We saw first that linkage was best in Johannesburg, and what this actually translates into is over 90% of known HIV positive women have voluntarily linked themselves to care within 30 days. It's below optimal in the other 2 sites, but in both cases that translates to roughly 3/4 of women aware of their status linking themselves to care. That's as good or better than estimates for the general population in South Africa. So the real losses are occurring between linkage to care and going on ART. The limitation of this data is that we don't have CD4 data that can tell us retrospectively if these losses or these gaps are attributable to a loss to follow-up or ART ineligibility. But prospectively, the data is indicative of the challenge of early treatment or treatment at diagnosis for the sex worker population in South Africa. A few other limitations are continuum indicators were self-reported. We didn't have biomarkers available for them. That was primarily a budget consideration, and this will not be a consideration going forward in our surveillance program. We do have some potential underrepresentation of subgroups in addition to what I mentioned about brothel-based workers in Durban and Cape Town. We did not get a large number of internet-based sex workers. Using RDS, you need to be networked, and it's, as we heard, it's probably luxury sex workers from the presentation before are probably not well networked to other sex workers. They're probably working solo. And finally, the data are from metropolitan sex worker environments and metropolitan healthcare environments. It's very limited generalizability to rural and less well-served environments in South Africa. And in fact, our group already has some data coming in from a rural project in the Free State and KZN that show that things are not even as good as they appeared on that very unfortunate slide that I just presented. So to conclude, we have evidence of a severe, rapidly advancing epidemic among female sex workers in South Africa and an urgent need to intervene with all available biomedical prevention and treatment tools. The good news, again, sex workers already accessing available healthcare services. They're not necessarily a hidden population. And this is an important opportunity, and at present it's a missed opportunity to promote prevention behaviors, biomedical prevention, and engagement in care in this population. The structural and work environments that sex workers work in are not all identical, and so a nuanced approach to intervention is going to be required. And ultimately, I want to stress that the IBBS that we conducted shows that there is a critical need to continue to collect routine strategic information to inform and evaluate the sex worker and all key populations' epidemic response in South Africa. So finally, I do want to thank my partners again at ANOVA and WIT's Reproductive Health and HIV Research Unit, our South African government and U.S. government partners, including CDC, the National Department of Health in South Africa, and the South African National AIDS Council, and our partners who are working with sex workers on the front lines, with Lifeline, Sisonke, SWEAT, and the TB HIV Care Association of South Africa, and finally to the 2,180 women who participated in our survey. Thanks very much.
This paper is now open for questions, and if I may start, Dr. Lane, these are very important findings. What kind of impact have they had in South Africa?
Well, thanks very much for the question. The the prevalence figures obviously were eye-popping for people who even suspected that things were not going terribly well for sex workers. We have been able to have conversations with our partners, with CDC, with the South African Health Ministry, with the South African National AIDS Council. So the impact of these results are being discussed, and I do believe that action will be taken on the basis of this, including biomedical prevention, including increased access to treatment for sex workers.
Thank you. Mic number 1, please.
Hi, Anna Forbes from Washington, D.C. again. This, I know, is outside of the scope of your paper and totally anecdotal, but I'm just wondering if you have had feedback from SWET and Sonke and those organizations regarding why they think this is happening. Is there sort of any kind of general consensus among the community organizers as to why women are not getting onto ART?
Thanks for your question. I've not yet had the opportunity to sit down in a structured stakeholder dissemination environment with them. Our primary focus has been getting these results to the ministry before we could begin disseminating at a wider level. That is going to happen in South Africa in the coming months, and I think that we will be getting that kind of anecdotal and data out of discussions. No data in the survey, however, does speak to your question, and I think that's a limitation of the method.
Thank you.
Thank you.
Sure.
Mic number 6, please.
Hi, Nina Hazen, PSI. Thank you. That's very important data, and thanks to all the speakers for very important studies. Tim, you mentioned there was a survey that was done alongside the biological data collection, and I'm wondering if there's information in that survey about why women aren't on ART. Were they on ART and dropped off, or have they not ever been initiated?
Thanks for that question. It's a really important one. We did look at women who were HIV positive and were offered PMTCT. Many, but not all of them, were retained, and again, that was, it was not policy to be retained. That was also retrospective data from 5 years. So the fact that we did not have CD4 data to know who was eligible and who wasn't, and the fact that we don't precisely know when in those 5 years women were on PMTCT and dropped off, limits our ability to really say with any definition, but I suspect it's a little bit of both, and prospectively, again, it's indicative of what South Africa has to meet to come to the 90-90-90 goals.
Thank you.
Thank you. 2 more questions. Mic 2, very brief questions and very brief answers, please.
Thanks, Tim, for an excellent presentation. My name is Harry Hausler. I'm the CEO of TB HIV Care Association. We're one of the partners working in South Africa with sex workers, and we provide a peer-led mobile health service. And I think we've been able to show in the last 3 years we've doubled linkage to care from around in the mid-30s to, as you showed, around 75% of sex workers after being diagnosed with HIV linking to care. But I think we do need to look at alternative service delivery mechanisms, and so we've started now Netaquini to initiate sex workers on ART in collaboration with the local clinic. So it's not really a question, but a comment that there are alternative service delivery mechanisms should help us to ensure that more sex workers access treatment, and community distribution points might be a way to ensure that they're retained in care. Thanks.
Next question, please.
Hi, Rosalind Coleman from UNAIDS. Thanks very much for your presentation. You went on to talk about then biomedical prevention and linking to treatment. And in terms of providing the two in the most effective and non-stigmatizing way, I wonder how